dedicated OCT guided plaque modification in complex PCI.
Good afternoon. Thank you, Dr. Patel and your team for this opportunity. I think we can all agree that the key to a successful PCI technically, when we are stenting a coronary artery, is a well-opposed stent in a well-expanded vessel. And the key to a well-opposed stent in a well-expanded vessel is a well-prepared vascular bed after adequate plaque modification. So how do you get good plaque modification? You need to use the right tools, which include non-compliant balloons, cutting balloons, high-pressure balloons, rotablation, etc. And how do you decide what tools to use? You need to first know what is the morphology of the plaque that you're dealing with. And how do you know that? You know that by using intravascular imaging. So let me give you a couple of examples. These are some of my cases which I've done in the last few months. And so this 78-year-old gentleman has previously had angioplasty. He came with class 3 angina, and I'd like you to focus on the LDL here. There's a very tight lesion, as you can see there. And did a OCT run here, which I'll probably abbreviate and show you the still frames. And you'll see that this patient has a virtual buffet of what types of calcifications you can see. You see superficial calcification, you see concentric calcification, you see eccentric calcification, and you see a nodule. So what do? I went ahead, I applied intravascular lithotripsy. We had some opening of the LAD post the IVL, and I used a 3 millimeter OPN balloon. We got even more expansion. And once we did that, we repeated the OCT to look at how much we had modified the plaque. So dissection, which is good. And you see here, there's a lot of cracks in the calcium. This will ensure that the vessel becomes more compliant. More cracks, and you see this nice little crack here as well. And cracks here. So following that, went ahead and stented this vessel with a 3.5 by 38 stent. And when we did the OCT distal edges, very good. The apposition in the mid part wasn't so good, which we tidied up. And even in the region of the nodule, there is good apposition, and the vessel area is very good. So while it may not be a nice round shape, it is certainly well opposed with achievement of a good luminal area. And the proximal edge is good as well. Now, we can't get an IVL down in every patient. So this is an example of one such gentleman who was in his 60s. He came with a non-ST elevation MI and a left dominant circulation. And I'm not sure how well you can see this, but the mid LAD is extremely tight. And so I could get a 1.5 millimeter balloon, which crossed very easily, but the lesion wouldn't yield when I used a bigger balloon. I had to use guideliner support for this, but the lesion won't just yield. So since it's not balloon expandable, this calls for a change in strategy, which was rotablation in this scenario. So 1.5 millimeter burr, and then expand the lesion. And then we did an OCT, which showed a mixture of various pathologies, fibrofatty plaque, there's eccentric calcification, dissection induced by the balloon dilatation as well as an intramural hematoma. And there's a thick plate concentric calcification as well. So again, IVL used, and then 2 overlapping stents, because one, the vessel length as well as the proximal vessel diameter was 3.5. So 2 overlapping stents, good angiographic outcome, and on the OCT, very good apposition for the most part. Distal edge is very good. Some malapposition here, which again we tidied up, and the most heartening thing is the placement of the stent, the proximal stent. It's bang on at the ostium of the LAD without too much protrusion. Now, if you think it's all about calcium, it's not. So sometimes non-calcific lesions can also cause problems, like it did in this gentleman who was an obese 62-year-old. He had 3 vessel disease, and I'm showing you the circumflex lesion, which, as you can see, looks quite complex. Very tight, tortuous vessel. So up front, balloon dilatation with a 2.5 non-compliant balloon. I also used a 3 millimeter angiosculpt for better balloon preparation or lesion preparation. Did an OCT. Didn't have a lot of surprises. Some dissection, intramural hematoma, a bit of calcium nodule, but again, as you can see, the area is quite good, and a lot of dissections induced by the ballooning. So yeah, I mean, it's all okay. So what could go wrong? So took a 3/38 stent. We measured the proximal stent to be about 3.5 and the distal to be about 3. So stent tracked right through, no problem. Deployed, and again, I'm not sure whether you can see the mid part of the stent very well, but it's not expanded very well here. And this is not the region where we had a lot of calcium. So what do we do? OCT, let's look at what happened. I'm going to let this run. And as you approach the narrowest segment, you will notice something which none of us like to see. The stent is not expanded at all. And this was in a vessel where we had used even a 3 millimeter angiosculpt. And this is what it looked like. So not a very pleasant sight. And so went in with a 3.5 by 12 non-compliant balloon. Made absolutely no difference. And then went in with the opium balloon, took it up to about 35 atmospheres. And one of the aspects which I've encountered a few times before is that the moment you deploy an opium balloon, it doesn't mean the vessel will just fall into place. Many times you have to keep it inflated for a much longer period of time. In this case, I had to keep it up at about 35 seconds when it actually gave way. And then this is what we saw. This is the post-dilatation opium. You see that area is expanded very well, and there is that appearance is gone. So we use intravascular imaging for various indications, but in the setting of an intervention, it's very useful as a pre-intervention assessment. It guides us how to prepare the lesion and which stent to deploy, what pressures to deploy at. And it also helps us to assess the post-procedural endpoints and complications, where it is unexpanded, malopposed, if there are any dissections, all those aspects we will come to know. And as far as calcium assessment is concerned, I think OCT probably scores over IVUS, and when you have severe calcification, then you could use all the available tools appropriately in order to get the best outcomes for your patient. So to end, we are seeing more and more complex lesions, but our armamentarium is also expanding, and I think the key is defining the morphology of the plaque with intravascular imaging. So once you know that, you know how to modify the plaque and ensure that you oppose the stent well and expand the vessel appropriately. So as we said earlier, well-opposed stent in a well-expanded vessel is how you get a good outcome. Thank you for your attention.